here we have half of the lesson left, so let's continue. Okay, so we have stopped at antidepressants. These drugs are described as ones which remove depression, but you know that depression is a complex of different symptoms. So when we are talking about removing depression, we are talking about diminishing the scale of the emotional changes in the person. So for example, if before the treatment the person was in despair, after the treatment they feel more neutral. So the antidepressants, they do not make you euphoric, fortunately or unfortunately, but they diminish the emotional resonance so that these emotions you feel become bearable to you. So this is the first thing. Also, a lot of antidepressants have an additional property of enhancing cognitive abilities. So the person suffering from depression no more feels that they are subjectively dumb, for example, so that they have better ability to concentrate. So attention gets more flexible under antidepressants. What else? What else? I have told you this, I have told you that. Also, in depression, a common symptom is vital grief, pain in the heart region, pains in all the body when the depression becomes somatized. So in this case, we have antidepressants which not only affect serotonin edging system, which mostly affects attention and cognitive abilities, but also noradrenergic system. So we tackle neuropathic pain, for example, for patients, as well as antidepressants can enhance the feelings of anxiety, so they may relieve anxiety for the person. Once again, because of these constant changes in the state, whether the person needs to find something or whether the person needs to sit still. So here is that. So, as you have guessed, most of these drugs suppress the neuronal reuptake of monoamines, and they can be non-selective or selective. So, for example, non-selective effect is of imipramine, amitriptyline. Selective blocking of noradrenaline is maprotilene. And when we're talking about selective blocking of the reuptake of serotonin, we're talking about fluoxetine, sertraline, citalopram, paroxetine, all this stuff. There are also drugs from the group of MAO inhibitors, so inhibitors of monoamine oxidase, irreversible, which inhibit both A and B subtypes of monoamine oxidase, such as neoamine, transamine, and reversible with selective effect, which only inhibit A type, such as moclobemide. So, if we talk about the lines of treatment of depression, first of all, we need to use the most selective ones with the least toxic side effects. So it is the selective blockers of the reuptake of serotonin, such as fluoxetine, sertraline, citalopram. If this line fails, for example, we may try the second line, which is MAO inhibitors. And the third line after this is usually the non-selective blockers of the reuptake of monoamines, such as imipramine and amitriptyline, because they are very powerful, they are very potent, but they have a very toxic effect on all the systems of the body, and amitriptyline in particular can cause urinary retention very early on. So sometimes you may want this effect, but I urge you to prescribe such potent drugs only in the conditions of the hospitalization. So yes, this is another thing. If our patient has troubles keeping an eye on their prescriptions, the patient is not as disciplined, yes, they miss the pills, they take more than needed or less than needed, or for example you need to try a more potent drug which has to be carefully monitored. then it is best to try all these experiments in the hospital during the hospitalization in the hospital. Ambulatory treatment is used for the patients who can comply with the treatment by the discipline overall. So here is that. Okay. And okay, so that overall, let me talk about everything according to the plan, because I will just mess up everything if I try to tell everything at once. So also, if you talk about the action on the psychotic symptoms, the antidepressant can also be divided into the stimulatory antidepressants such as imipramine, petilene, nialamide, anafranil, indopan, incasan. Also, with sedative effects such as amitriptyline, furosemide, also azofen, trazodone, and with stabilized stimulatory and sedative effects, so fluoxetine, aprotilene. So we actually fear antidepressants which have stimulatory effect, because if before your patient was inhibited by the depression, and these drugs, they enhance the movement, first of all, the movement and the reaction. So now the person may have energy to finally make their dreams of committing suicide true, because their ideas about themselves, about the world around them, delusional ideas maybe, they changed in the last part of the treatment. So that's another thing we fear, and you should be very, very careful. So if you administer the drug which can activate the patient, and you know that the patient has suicidal thoughts, it is best once again to try such experiments within the hospital, because well, it can result in death of the patients. So here is that. Also, another thing, if the patient on the antidepressants falls into the manic phase, now you know that the patient has bipolar disorder, and this means they need not antidepressants but mood stabilizers, and we'll be talking about mood stabilizers as well. What else? We talked about all this. About all that. Okay, so about antidepressants once again. Most of them can get you overweight, unfortunately. They can cause insulin sedation. Some of them can cause diplopia because they have anticholinergic properties. About MAO inhibitors, why they are second line drugs? Because they can rapidly, if you are talking about irreversible ones like nialamide, they can rapidly increase the amount of serotonin in our body. But serotonin is also secreted and made from the products you ingest. And this should be taken into account, because unfortunately a very dangerous side effect of these drugs is called Citronium, malicious serotonin syndrome. In this case, the person becomes hyperparetic, they may suffer from convulsions, and they may die in this condition because of the abundance of serotonin in their body, because just the ferments which break down the serotonin, they are off at the moment. And in this case, the patients taking these drugs should be very careful. They should be following a certain diet. For example, they should avoid cheese and certain types of wine in order not to make too much of the serotonin in their body. So here is that. There is a variety of anesthetics prohibited from being prescribed to these patients because of their very effect on the serotonergic system. In this case, for example, there is a restriction on the operations these patients should have, and for example, we need to taper down the drug before the patient has the planned operation, and it has its own risks always because of the diminishment of the antidepressive effect. But overall, these drugs are actually very, very good. So if you know how to follow these rules, what to eat and what not to eat, which drugs can be combined and cannot be combined, you're cool. And in this way, for example, Mao inhibitors should not be combined with the other types of antidepressants which also act upon serotonin-aging system, because once again you cause this malicious syndrome to your patients and their death. And therefore a lot of physicians actually fear this type of drugs. But once again, everything comes with practice. It is just that you should be very, very careful with dosing and with understanding what is happening with the patient. So, themostabilizers. Themostabilizers are called like this because they help, once again, to diminish the emotional response both from the depressive spectrum and from the manic spectrum. But this depends on the concrete drug, because, for example, lithium is mostly anti-depressive one. For example, while others can be anti-manic. So here is this. Not to mention that in order to get a more pronounced anti-manic effect, we can use antipsychotics in conjunction with themostabilizers. And this is another thing. So if you do not get the desired effect from a certain preparation for a long time, and you do not want to change it, or if you, and this is preferable, if you get a partial effect, so you see that it helps but a little bit, so it should be adjusted by something else, you may add an adjunct preparation. So for example, you see that lithium helps but not that much, so the person is still manic, we need to add antipsychotic. But it is best to use augmentation by another preparation when we have partial effect, because otherwise you just treat the person with a variety of different medications at once and they will not have as useful effects. Okay, so themostabilizers mostly are represented by lithium preparations. Lithium is very good for bipolar disorder. It is very cool. Its mechanism is bound to the ion channels, and therefore, and this is not written in many instructions, but I have stumbled upon this on practice while we had this person on lithium going through war without any supplies of her drugs, so we had to taper lithium down, as well as antipsychotic quetiapine, which was going with the lithium. So the thing is that the lithium is very, very toxic, and the therapeutic window is very, very small. And this girl who was having these lithium dosages diminished, so they were actually smaller than they were before the war, as well as dosages of quetiapine, which is an antipsychotic drug, which was also diminished. She started showing me the signs of lithium intoxication, and this was very, very surprising, because the dosage was higher before, but she wasn't showing it. And we had no way to direct her to the hospital, because the village she was staying at, there were no way to call the ambulance. She was during the war actions, very, 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 very close to her. So since I knew that lithium could be eliminated from the organism much faster if there were supplies of sodium in the organism, I advised her to drink salted water. It was not very professional probably, but it was the only thing I could do in that situation. So just to stop her lithium intake at all and give her this salty water. And this is what is not written in the instructions. Sodium helps, like the deficit of sodium makes lithium to stay in the organism for longer, so it is accumulated, and so it may get you the symptoms of intoxication overall. And I would argue that actually this patient, before, she was intoxicated by lithium chronically, but we couldn't see these symptoms because quetiapine is antipsychotic, and she was taking quetiapine in very high dosages. It was hiding those symptoms because it was like it had a contradictory effect on muscles of this person and on the ion changes in her body. So therefore we couldn't see it before. But now I saw that she was getting intoxicated. So such things happen. So lithium, yeah, very potent drug, very effective one, but very difficult to manage because you need to measure the level of lithium in the blood constantly. And that girl, by the way, she wasn't measuring it at all for maybe like 6 months. So it was a very, very, very difficult situation. So please, if you have an ability to measure the level of the lithium, okay, you can prescribe it. But if you cannot, it is best not to get into this mess and try alternatives. So what are other alternatives? Other mood stabilizers include mostly anticonvulsants, because our changes of the phases in the bipolar disorder, they look like paroxysmal states, so they appear suddenly like splashes of impulses. So anticonvulsants can help with the impulsivity which goes with these states and with these states emerging. So other types of drugs is valproates. They increase inhibition of GABAergic receptors and prevent the development of manic and depressive phases. Also, for example, there is lamotrigine. Once again, acts at sodium channels. Carbamazepine, also indicated for dysphoria in epileptoid psychopathy and epilepsy. So all these drugs can help. The problem is that they have a very bad effect on fertility on the patient, and they can be teratogenic, and this is something you should take into the account. Basically, we suppose that all our psychotropes are excreted via breast milk, but not all of them can pass the placentary barrier, but these ones, anticonvulsants, can. So be very careful. If you have a pregnant patient at your hands, maybe you should once again see and look for alternatives, maybe even antipsychotics in this case, because well, the effects can be very, very, very bad. Usually, especially when we are talking about valproates and carbamazepine, the patient should take folic acid in big amounts, because there were instances of spina bifida increasing in occurrence in the children of such patients who were taking valproates during their trimester of the pregnancy. Well, obviously not all parts of the pregnancy period can be as dangerous for the child when the patient is taking certain drugs, but once again, it is not good to risk it. Okay, about psychostimulants. Psychostimulants are mostly used for static states, attention deficit and hyperactivity disorder, and catatonia, and they improve mood, ability for perceiving external stimulants, psychomotor activity. They reduce the fatigue, the person stops sleeping, the person doesn't really need to eat. So it is good in moderate cases, but there is also a side effect. Psychostimulants can cause psychosis and also addiction. So you should be very, very careful with them. So the following medicines represent the psychostimulants, such as phenyl, alkylamines, such as phenamine, also methylphenidate, hydrochloride, which is used for ADHD, sidnocarb, which is used for stenic states, catatonia, methylxanthine, so caffeine. All of us are just happy with caffeine. I am a happy caffeine addict, but I don't drink coffee. I prefer tea. For some reason, coffee is just strong for me. I don't know why. Maybe it is a placebo effect. And also bemetyl. Okay. Also, there are such substances such as modafinil and modafinil. They are food additives which have the properties of psychostimulants, and they are usually used by people who work out in gyms in order to lose weight. But you shouldn't, once again, you shouldn't overuse them as any other substance. Okay, so sidnocarb, it is a Ukrainian drug preparation which doesn't cause addiction, but overdosage can cause sleeplessness and short temper and restlessness, and should not be administered in psychosis. It is only for somatogenic asthenia. Okay. Now, nootrops. So what are those? Nootropes enhance higher cognitive ability, enhance memory of the person, and helps overall in the intellectual activity. So it is prescribed a lot for people with organic disorders, for people who suffer, for example, from the consequences of somatic disorders, infectious disease of the nervous system, such stuff. They have a variety of groups inside of them. So there are GABA derivatives such as piracetam, phenibut, amino-1. Also combined ones such as pantogam. Marine vasodilators such as camentone, samidone, nintocetin. A very beautiful thing for all the alcoholics to have. And also different like tingogene and cephadol, tancan. A lot of this stuff should be titrated down very, very carefully. I had this patient who was just eating phenibut just for the sake of it, and she suffered a lot from the withdrawal syndrome, so you shouldn't take it just without any prescription. And about nootropes, many students have this legend going around that if they take a nootrope, they will pass the exam. No, you will pass the exam if you actually learn, if you study your subject. Nootropes help when there is actual problem in the nervous system. Then they will help. If you just eat nootrope just for the sake of it, you get all the side effects, but you get no positive effects. And this is also an important thing. If you have a patient who had tried a lot of psychotropes and all they get are side effects and no intended effect of the drug, this either the dosage was wrong, or this person actually doesn't have a change in their physiology, which requires the administration of the psychotropes. For example, I have talked about ADHD, so people with ADHD have an abnormal reaction on psychostimulants. They become relaxed, they become sedated on psychostimulants, while people with normal physiology become activated. And that's another question I ask people when I'm trying to decide whether they have ADHD or not. How do you react on coffee? Do you become sleepy on coffee? If they become, most probably this is a real person suffering from the ADHD. If they not, probably their problems with attention are functional and not inborn and engraved in their physiology. And this is very important because for some reason people think that psychotropes, nootropes included, but psychotropes in general are like vitamins. You can take them, you cannot take them. Well, they do something good for your organism. No, you do not take medication without indications because they mess up your physiology. And this messing only helps people who actually have disorders. And that's why they need these psychotropes. If you do not have a disorder, you will mess up your organism by taking the medication. So I'm becoming very emotional right here, but you have to deal a lot with the consequences of people not being wise with their choice of medication, and then they always blame it on doctors, obviously. And this is very, very hard. So please be wise and be careful with your organism. It is no jokes, it is not a game. Our drugs are not vitamins. Not to mention that even vitamins shouldn't be taken without medication because, you know, those vitamins who dilute in fat, they can be accumulated and they cause intoxication of our organism. So please do not overuse E, D, A, and K vitamins. So those ones. Okay, so about nootropes. Let's return to our topic. Well, there is not much to say about them. So I have already told about names and their main sites of action. So that's all about nootropes. Nootropes are used mostly in organic registry of psychiatric disorders. So different dementias, oligophrenias, people suffering from neuropathies, people suffering from intoxication, such stuff. Just the protective act upon the nervous system. Okay. What else? Okay, so in the presentation there will be also different brand names, which I won't be talking about right now, but you'll see them. Okay, also about treatment. So electroshock treatment, electroconvulsive therapy. It is used in the resistant cases. So there are electrodes which are applied to the patient's temple, and we need to get the tonic convulsions of the patient. Wait. No. We need to get only conic convulsions of the patient, so that we don't need the effect of the patient, like defecating themselves and urinating themselves, like in epilepsy. No, but we need to get up to the seizure threshold just a little bit, because what we need is not the lengthy seizure of the patient, but we need to get the effect of breaking down the effective neuronal circuits, which were sustained for a very long time, which were the authors of psychosis, for example. So electroconvulsive therapy is used in case of febrile schizophrenia, in case of paranoid states with acute hallucinations which are treatment resistant, in cases of severe depressions with the risk of suicidality, which are also treatment resistant. So in such cases, it looks very scary from the outside, but actually the patient is unconscious during the procedure and they do not remember what was happening. Mild relaxants can be administered before this in order to not cause fractures in the patients, because sometimes this may happen. Also, there are serious contraindications. So, for example, if the person has unhealed fractures, we do not use electroconvulsive therapy. If the patient has severe atherosclerosis, we do not use it. If the patient has artificial driver of the heartbeat, we do not use it. So a lot of this stuff. But it provides, this therapy provides a very quick effect. So improvement of the symptoms from the first therapy, and that's cool. But what is not cool is that it's not a long term. So unfortunately, overall, over time, the effect will diminish. So we should repeat this again and again and again. And we have these big journals where each patient is recorded, how many therapies they have gotten and at which time, and this can go up to 1 year or even 2 years, depending on the case. So here is that. Okay, yeah, insulin shocks. So the patient was given them big amounts of insulin in order to cause the hypoglycemic coma, and then they would get back to their senses by infusion of glucose. Once again, it is a very aggressive way of therapy, and I was talking to an endocrinologist who was severely disapproving this type of therapy, because he told me that, well, you know, like the person loses consciousness and falls into a coma, it is an impact on the brain. Like, it is not a very good thing to do. But unfortunately, this was used as one of the main treatments before, as well as atropine shocks. But as you see, atropine shock is even more scary than insulin shock. So they are not used right now. So psychosurgery, once again, most popular and most common psychosurgery was the removing of the associated tissue between the hemispheres. Usually these operations are done through the orbit. Very good thing in order to diminish aggressive behavior. But in the long-term therapy, it was obvious that there was a side effect in the form of diminishment of cognition. So the person will become demented in the long-term perspective. So obviously right now it is not used, only once again in very desperate cases, and obviously if the person needs it and wants it, because nobody would do such operations in you. Not very popular because unfortunately if you sever parts of the brain, you cannot sew them back again. So here is that. Also, yes, psychotherapy and social therapy. So social therapy includes a lot of different factors. So it is improving the environment of the patient, enhancing the living conditions, enhancing the closest circle of people they talk with. And this is very important because I have mentioned before that our patient is a part of the system, so we need to change the system. So here is that. Also, acquiring social skills and acquiring certain working skills because of the illness. Most of our patients need to change the place they work at, change their occupation. So this should be covered. Before there were workshops near the hospitals. Right now it is not as popular. Okay, about psychotherapy. Always look at the type of the illness, at the type of personality of the person you are working with, and remember your goals. What do you want from the person and from this psychotherapy? Because each psychotherapy works best on a certain kind of person. So, for example, if you're talking about hypnosis and suggestive techniques, people with histrionic traits will love them. They will give you all information while they're in trance, and this works much better than cognitive things. When you are dealing with psychasthenics, for example, especially the ones with obsessive compulsive disorder, obviously cognitive behavioral therapy is very useful. So we need to make new patterns for the person. Cathartic therapy can be used, I would say, in all patients who do not show signs of psychotic symptoms. So once again, releasing the emotions. Also, working with metaphors. A very interesting thing, because it should not be given to the patient suffering from delusions and problems with thinking, because they will distort the metaphor. And you remember that we usually use the metaphor as examination for such patients. But it is very effective when rationality doesn't work, because I would say that even the most intellectual patient you have has a certain level of oppression against the treatment, or struggling, yes, against the treatment. And so on their words, consciously, they will tell you that they will follow your instruction, they will do everything perfectly, they understand what to do and what for. But then they return to their homes and they do not do anything, like at all. They don't take pills, they don't follow your instructions, because there is emotional factor here. And this factor may be unconscious in many cases. And so when we use metaphors linked with the rational therapy for such patients, we counter these barriers which are unconscious, because the patient cannot decode what you mean by metaphors. But you can deliver the message you need to the patient via these metaphors. And when I'm talking about metaphors, it's not like just literal metaphors. It is certain stories and patterns which will be useful to the patient encoded in your speech in such a way that the patient doesn't notice that they've been encoded there. It requires practice. It requires certain knowledge to work with metaphors, but it is very effective. So I would say that it should be used alongside other methods. People suffering from stress will benefit from autogenous techniques on relaxation, especially those who suffer from somatization disorders and they have very low reflexes, so they are not able to reflect on their own states. They only hide it in their body, so we should work with the body. What else? Existential therapy helps people who are in depression, for example. And also there is such therapy called logotherapy, so it is the therapy with the meanings, and it is especially effective in distressful situations. So right now it is the war in Ukraine, for example, and we are working in terms of logotherapy with a lot of patients, because they cannot change many things which are going on right now, but they can influence their own perception of these things based on the meanings they attribute to the events. So this is logotherapy. Also, systemic family therapy, once again, based upon the idea of the systems, can help in the cases when the patient doesn't give you enough information. So you can quickly approbate your hypothesis in working with them. But once again, depends on the type of the patient you're working with. What else? Well, coaching techniques, once again, used with more rational patients and the ones which will follow your instructions, which know what they want, which need practical skills. They have to repeat over and over and over again in order to remember what to do, in order to enhance their life. Metacognitive therapy, I have mentioned before, for people with delusions and hallucinations, mainly people with schizophrenia. What else? Well, that's basically it. Psychotherapy is another very big art, which is unfortunately not taught to the psychiatrists in Ukraine, and I do not dare to speak more of it because I do not have enough competence, but I have some competence because I was present on the group psychotherapy for 4 years now, and I was working in conjunction with psychotherapists there, so I have observed some of his methods. Okay, we can work with this, we can work without that. I have talked about this, I talked about that. Oh yeah, also psychoanalysis. Psychoanalysis is very effective when we need to get rid of the reason why the symptoms happen. But other than that, it may not be very useful for the patients. So when we can get rid of the reason, it is the way to go, especially people with the intellectual type. But if you are working, for example, with a person who has been living in the village all their time, and the most feared thing is to not be able to replace the cow they have, well, probably psychoanalysis is just too deep for them. Maybe you need to find something more practical for the person, and it is not because like there was people or something like that. No, you need to have a therapy which fits the needs of the patient first and foremost. Therefore, they will have less struggling, and therefore it will be more effective for them, because all these therapeutic methods, all these cool suggestions you give the patient, all these cool recommendations, they need to be repeated and practiced. And if the person doesn't have a situation at which they need these patterns, they will not repeat them, they will not train them, and therefore there will be no effect. Okay. Also, group therapy, yeah, there may be 3 types of therapy, so individual, collective, and group one. The difference: collective therapy, in collective therapy, each member of the group influences the therapeutic process of another. So I actually attend collective therapy. When we're talking about group therapy, it is when the psychotherapist is still a central figure and he influences all of the members. So this is group therapy. And individual, obviously, it is one person working. Psychotherapy, family psychotherapy is also very popular, especially when you work with children. You have to work with their parents, always have, because it is a very crucial thing to do. Okay, we can talk about this. Okay, so last part of things, psychoeducation. So psychoeducation has to form an adequate idea about the disease and patients and their families, in order for them not to think that, for example, schizophrenia is the possession of the spirit of fire, for example. So it is not what it is. Also, psychoeducation reduces emotional stress caused by the fact of the mental illness. Also, declines the level of stigmatization in patients. Gets the patients to the role of this pharmacotherapy. Educates the patients and their families to recognize the early signs of worsening. This is very important because there is a very little gap of the critics in some of these illnesses, which we have to catch if you want to help the patient. We increase the compliance by psychoeducation and stuff. So all this stuff. And when we are talking about mental hygiene, it is a set of measures for preservation and promotion of mental health. So in In Ukraine, for example, there are some families in which it is perfectly normal for people to go around naked. But the problem is that, for example, there was the family where two daughters were walking around naked in front of their father. And yes, okay, this happens, but they were already 25 years old and they were still walking around naked. And despite the taboo of the incest and such stuff, their father would get aroused. And he, of course, would suppress it. But the tension is still here. And it would affect those girls as well, because they feel this tension. But everybody would be quiet about it because it is taboo. So obviously it is not a very good mental hygiene. Another example of a bad mental hygiene is your friend who constantly brags about how everything is bad in his life and he only uses you in order to brag about bad things in his life. So you know those people. That's not a very good mental hygiene if you allow this to happen, because afterwards you feel shitty about your life, not your friend. He will feel better about this. So here's that. Okay. So what about this? I have talked about this. I have talked about that. I will tackle the psychoeducation, psychoprophylaxis, and mental hygiene very on a very superficial level, because it is mostly like a social aspect and it is mostly a psychological aspect and not psychiatrical one. So here is that. Yes, and psychoprophylaxis is a complex of measures for preventing mental disorders. Okay. Once again, there is primary, secondary, and tertiary prevention. So primary, before the person gets ill. Secondary, we prevent the complications of the illness. And tertiary, we work with what is left after the person has suffered an acute case of the illness. Okay, what else? Yeah, also about rehabilitation. There is professional rehabilitation and occupational rehabilitation, and there is difference because in case of professional rehabilitation, the person works at the same profession, but they have a changed set of their needs and skills, of their functions and their places they work. And then we're talking about occupational rehabilitation. The person may need to change the occupation in order to continue working. So here is that. Well, this is basically it. Thank you for your attention, and this was the last lesson in this course. So maybe in a year I will review these lessons if I'm not too lazy, maybe not, but definitely by that time I will have more to tell you. So thank you very much. See you.